Hello, everyone. Uh, we'll be talking today about a topic which is kind of, I would consider a CAM therapy topic. Okay. So remember, we started the series of our CAM therapy presentations here. We talked about CAM therapies in general, and then we talked about biomedical acupuncture. And in this presentation, we'll be talking about um, biomedical injection therapies. And to be honest with you, this terminology is something that I came out with to be inclusive to all kind of, CAM therapy injection, in the practice of pain management. Okay. Um, we'll start with giving you an introduction about CAM therapies. CAM therapies is defined as a group of diverse medical and healthcare systems, practices, and products that are not generally considered part of conventional medicine. CAM therapies plus conventional medicine equals integrative, or what we call holistic medicine. Will explain, as an introduction here, what is acupoints. Okay, acupoints are certain points in your body. Uh, they have certain characteristics, guys. According to Dr. Hu Qidong, who was a professor of anatomy and acupuncture in San Antonio, Texas. This gentleman, he biopsied one, he biopsied the most famous acupuncture points in the body, and he made some correlations here, and he found that they have a special pattern. Okay, like the size of the nerve, the depth of the nerve, emergence from deep fascia, passage through the foramina. For example, supraorbital nerve comes out of a foramen, right? And this makes it, you know, more accessible to needling than other points. Neuromuscular attachments. So acupoints that are present or located above neuromuscular attachments will probably give you better response. Concomitant blood vessels, composition of the nerve itself, nerve bifurcation, sensitive ligaments, and suture lines of the skull. So these 10 characteristics define the anatomy of acupoints. Another important physiology, concept here is the Hilton law. And in Hilton's law, we say here that a nerve supplying a joint will also supply the muscles moving the joint and the skin covering the distal attachment. What does this mean to me? It means to me that, the skin, the muscle, and the joint are basically one unit. And if you, needle any part of this, a complex structure, you will get response that will be transmitted to the other parts of, the joint, you know. So this is a very important concept, and we're going to see it in our presentation here. All right, I kind of, wrapped up all these biomedical therapies into 6 groups. Okay, neurotherapy, biomesotherapy, intraneuronal therapy, perineural injection therapy, biopuncture, and trigger point injections. We'll start with neurotherapy. Neurotherapy was developed by the Huenke brothers, who are basically dentists, in the mid 50s of last century here. Um, According to the Huenke brother, neurotherapy is a regulating therapy. That means it's a holistic therapy. Neurotherapy is a healing stimulus produced by means of correctly placed neural therapeutic substance, which is usually a local anesthetic, short-acting local anesthetic, such as procaine or lidocaine, which initiates a positive response from the whole neurovegetative system. Segmental therapy, according to the Huenke brothers, refers to selective use of procaine 1% or lidocaine 0.5% in the area of the disease process. If segmental therapy fails, look for interference fields. This is how we do neurotherapy. We inject, in the layer between the epidermis and the dermis, creating what we call blebs or quaddles in German language. Of course, you have to put these in a segmental pattern, okay, to achieve your, results that you're looking for. So you need to be aware about the segmental anatomy here. Of course, the trigeminal has its own, anatomical pattern here, different than the rest of the body, because you have three nerves supplying the face here: the ophthalmic, maxillary, and mandibular. You can evaluate the response using an infrared thermometer, and I've done a lot of these where I put after putting the quaddles or the blebs, I check out the temperature, and usually there's temperature drop after putting these material or the local anesthetic, and the reason is you actually you lower the metabolism in this area by injecting these medications, and when you do so, the temperature will go down. Another basic anatomy here is the autonomic supply of the body: head and neck, T1 and 2, upper extremity, T3 and 4, thoracic viscera from T4 to T6, abdominal viscera from T7 to T11, and lower extremity from T10 to L2. You should be aware of these autonomic supply as well, because this will determine where you put your local anesthetic. Interference field. This is basically an area that interferes with your treatment, okay? And if you actually inject the interference field, you get a very, fascinating phenomena called the lightning reaction or Huenke phenomena, where the patient will get, almost complete resolution of his pain after the injection. So some of the interference zones that we know about is the scar tissue. And I do this injection all the time, all right? Just infiltrate the whole scar with 0.5% lidocaine. And I like to bend the needle so I can get, as near as I can to the scar tissue. The sinuses, organs, and lungs, like like heart and lungs, liver, stomach, and then mouth. I created a mnemonic called the soma. Okay, so soma for scar, organs, then mouth. Remember, these folks were dentists, so they put a lot of interest on injecting the teeth here. And they said that there's a correlation between the teeth and different ailments in your body here. They just inject underneath the gum here, okay? Very simple shot. Anyone can do it. It's not really a very difficult one. But you have to know also there's a diagram that shows the, different teeth, connected to different organs. So, you need to know what are these connections, okay? And it's available in his textbook, about neurotherapy. So you should know about it before you attempt injecting the teeth. Autonomic ganglia is, part of the treatment because autonomic ganglia could be an interference zone. Of course, this procedure was performed in the 50s of last century. So most of them were done without, guidance, without ultrasound guidance or, X-ray and all that stuff that we have right now. Of course, there's no reason to do it, landmark techniques anymore. So how to identify these interference zones? And there's a very simple method called applied kinesiology, where you basically hold the patient's right arm while you're, getting very near to the areas in the body that's affected here. Once you will find a weakness in this arm, okay, or the right arm, you're probably putting your other hand on top of an interference zone. Okay, with neurotherapy, you inject acupoints. These guys were, they know very well, the traditional Chinese medicine and acupuncture. So they incorporated this in their neurotherapy technique. So you can say that actually neurotherapy is an contemporary type of acupuncture where you inject instead of just dry needling. You can also do joint injections. Again, all of these are done landmark techniques here. Again, with local anesthetic only, procaine or lidocaine, diluted. It has to be diluted, okay? Like 1% procaine or 0.5% lidocaine. Procaine is not available in the market, by the way. You have to order it from a specific, pharmacist, and they will send it to you. Facial and pain headaches. I learned a lot from these guys, by the way, and I do a lot of the techniques in my clinic, upper and lower extremities. But of course, I modified some of these techniques. The ones that I can use, ultrasound guidance, or doing it under X-ray. One fascinating injection he does also is doing an intravenous injection. Now, he doesn't use a lot. He just uses like 1 cc of lidocaine. That's about it. And it seems like it does the job in many cases because it gives you this systemic effect of the local anesthetic. We're going to explain how this works at a molecular level in just after a few slides. Okay, the trunk, sacroiliac joint, injecting the xephisternum. Okay, next technique is the biomesotherapy, which is basically same, almost the same technique like neurotherapy, with some differences. And this was developed by Michel Pistor, who is a French physician here. All right. Now, Pistor injected these, therapeutic agents, underneath, the dermis. Okay. So uh, he went a little bit lower than the neurotherapist. Okay. He injected in the dermis itself. And he called it mesotherapy because it's in the middle. Now, he utilizes this technique for cosmetics and also for pain relief, like in cases of tendinitis, osteoarthritis, lymphedema, and venous stasis. This is Michel Pistor, and the one that the thing that he has on his right hand here is basically, we call it the meso gun. Now, I want to tell you, these guys from dermatology use this mesotherapy technique all the time. This is like very familiar to them. Okay, so but it's not very familiar for pain physicians. I've done hundreds of these, and I want to tell you, it's a great technique and extremely safe. This is Pistor, in the middle of his other colleagues. Uh, Now, matrix regulation theory was developed by Alfred Pischinger, a German, physiologist here. And according to Pischinger, the matrix of the mesoderm, or you know, uh, the area beneath the skin, actually is connected to the whole body, and that's why you do an acupuncture, for example, in the foot, and it will have an effect on your upper body, on your headaches, on whatever, because this area is just covering the whole body here. Uh, Biomesotherapy, uh, as you see here, can be done for different pain problems like joint pain, and neck pain, upper back pain. You will not find a lot of literature about it in pain management, but in cosmetics, you will see a lot. And I want to say that I use a cocktail for biomesotherapy. I put local anesthetic, I put vitamin B12, I put magnesium, I put also ketorolac, which is toradol. I do a mix, and I put this mix in the dermis here with a special needle, very short needle, like 4 to 6 millimeter needle. Another technique is the intraneuronal therapy by Paul Pybus. Okay, and I want to say that Paul Pybus he had himself, some sort of a rheumatic disease, and he was determined to help the folks. So he developed a technique called intraneuronal therapy. He doesn't really inject inside the nerve. That's a misnomer. But he injects the cutaneous nerves, around the joint. And remember that we talked about you know, uh, Hilton theory here, or Hilton law, that the skin is connected, muscle connected to the joint. So when you inject in these nerves, it helps with the pain that you have in your joints. And you can see this from this picture here. Okay, it does, does help with with the nerve damage that happens around the joints and the muscle spasm. So in a disease joint, you have a muscle spasm that's squeezing the joint and actually uh, getting off all the nutrients out of the joint. So when you inject your medication, and usually this is a local and steroids, you get a muscle release. Trigger point injections developed by Jeanette Revel. She is the guru of myofascial pain. She used to be the private doctor for JFK, and she was a cardiologist. But she found that a lot of patients that comes to her emergency room, actually, these guys benefit from trigger point injection, and then she kind of dedicated the rest of her life to the myofascial pain disorders. Now, as you know, when you have a muscle spasm, it's like you're having a myocardial infarction. This actually will produce less blood flow and can lead to energy crisis. So when you break this, cycle, in fact, you break the pain here. This is just some of her myofascial maps here, like sternocleidomastoid, trapezius. Remember, a lot of these headaches that you see in your daily practice are just a bunch of, myofascial trigger points. Other trigger points here are lower extremity, like the quadriceps, for example, soleus muscle. All right, another technique that I learned during my stay in the United States was biopuncture, developed by this gentleman from Belgium here. His name is Jean Kerssot, and he has a nice book that you can buy. But anyway, Jean Kerssot uses, different techniques, neurotherapy technique, biomesotherapy. But the bottom line is that he's using basically kind of homeopathic agents, and basically the ones that are produced by a certain company called Heal. And this Heal company is a German company that has a branch in the United States, and he will take these agents and dilute it in local anesthetics and inject it in different parts of the body. And he injects in the subcutaneous area. So in neurotherapy, we inject between epidermis and dermis. Mesotherapy or biomesotherapy, we inject in the dermis, and this guy injected the subcutaneous and use homeopathic agents. Okay, this is just how it looks like. Of course, his method is less painful than the other methods, and I kind of use more of the biopuncture. Right now I found it, less painful to inject in the subcutaneous area than injecting in the epidermis, dermis, or the dermis. So I use the Kerssot technique here. I just go with a insulin needle, uh, and I just inject in the subcutaneous area. I go with an angle so I don't go deep. Okay, I go with like a 45-degree angle, and I inject like this picture here. All right, you don't have to use the syringe. You can use the 3cc syringe. Okay. Another technique that you need to learn about is John Lyftoght. This is how you pronounce his name, Lyftoght. And this guy is from New Zealand. He basically injected with dextrose. So he said, well, we don't need to use local anesthetic. We can just use, dextrose 5%. All right. So that's why he called it initially it was called a neural prolotherapy, and then later on he changed the terminology to perineural injection therapy. And he gives a lot of courses in the USA. It's the same concept, guys, but you know, he changed the agent. So what I'm saying, all these techniques are related to each other. Okay, I mean, and that's why I came out with this terminology, biomedical injection therapies, because it's very confusing. Unless you really get very deep into each of these, you will always be confused which is which. I consider them one thing with changes in either the component of the injectant or the anatomical structure that you injected. Okay. Uh, when you do inject dextrose 5%, you, number one, actually decompress superficial nerves, and also you downregulate the TRPV1, what we call the vanilloid receptors. All right, so how we decompress? The theory is as the nerve come out of the facial transitional zone, there's a constriction injury here. And this is why when you inject the dextrose, you release it. And this is how you treat the pain syndrome. And this picture shows that, injecting the 5W, it actually, down regulates this vanilloid receptors, or what we call the TRPV1 receptor. To do this PIT, you have to have an understanding of the anatomy of the nerves in the body and their distribution. So he utilizes, textbooks that, and these are very few, by the way, in the market, that describe these cutaneous nerves. I have one of them at home where I can, basically, it gives me all the cutaneous nerves. You can buy it from Amazon or whatever. And he uses only D5W. Okay. Now, to explain the biomedical, we talked about the techniques. Now, I want to explain, the difference between these techniques here. For example, if you're injecting in the epidermis, just in the epidermis, this is called the nappage technique done by Pistor. And this is the picture that I showed you where he's carrying the Mizu gun. I don't do this procedure a lot, but probably the guys from dermatology does for cosmetic reasons. So they use the Mizu gun to just, prick the epidermis. Now, if you're injecting like here between the dermis and the epidermis here, where you develop this bleb or quaddle, this is called, a neurotherapy or quaddle developed by the Huenke Brothers. If you inject in the dermis, which is here, using 4 to 6 millimeter needles, this is ideally speaking, a biomesotherapy. If you inject in the subcutaneous area, you're actually doing biopuncture or perineural injections here. If you're injecting inside the muscle itself, this is a regular textbook, trigger point injection as described by Jeanette Ravel. Now, you can also inject the periosteum, and this was described by the guys from, neurotherapy techniques, the Huenke Brothers. And, you know, you need a bunch of these needles if you're doing the procedure. But to be honest with you, I've done all of these. Okay, I don't. I just use this one here in the middle here. This is like an insulin needle, half an inch insulin needle, and I go with an angle, and I just inject in the subcutaneous space. This is my technique right there. I've done all this, other techniques, and I can tell you the response is the same. The only difference is if you're injecting in the subcutaneous area, it's really less painful than the others. And this makes the patient much more comfortable. And the results are the same. Okay. I don't see a difference. All right. Dermal, see the needles here, just a short 4 to 6 millimeters. Subcutaneous, these are longer needles, half an inch. The one that you have all over the hospital in anywhere in the you know universe, these are available. Now the short needles, you have to order them from certain companies. Like Airtight. There's a company called Airtight that sell these small needles. If you want to, okay, you can try practice some of these, in your clinic. But I'm telling you, from my experience, just use a regular half an inch insulin needle, 30 gauge, and do your job with it in the subcutaneous area. Of course, with the intramuscular, and sometimes you need to do that. Okay, you're gonna need a longer needle to basically, break down this muscle spasm and ischemia that develops from a trigger point. Medications. The most important are the local anesthetics, and we use only short-acting local anesthetics, such as lidocaine or procaine. We do not use bupivacaine, guys, all right, because this can actually cause, muscle damage, all right. Dextrose 5% is extremely important, okay, especially in the perineural therapy techniques developed by, Lyftoght, John Lyftoght. Um, Botulinum toxin. You can do mesotherapy or neurotherapy with the diluted botulinum toxin. NSAIDs, the most famous is ketorolac. I diluted with the local and I injected. Uh, B12, muscle relaxant. The most famous is magnesium, but you can use other muscle relaxants as well. Uh, you know, and then homeopathic agents. And I got you a picture here for most of these. This is a kind of a homeopathic agent that I used to use in my practice called Tromil, developed by a company called Heal. Okay, it's very useful. Despite I have a lot of skepticism, about homeopathy, but I cannot tell you that this actually to me is just very helpful, and I don't know how or you know, but I mean just a clinical experience. That's all. So I use this all the time. Injecting joints, injecting trigger points is just an extremely beneficial agent, and it's pretty safe. I know that you guys might get confused about homeopathy, but I myself I'm not a big believer. But this agent, for some reason, it does work. Local anesthetics. You see here the procaine 1%, lidocaine. I usually we use a half percent lidocaine. The local anesthetics are basically composed of a lipophilic part, linkage, and hydrophilic part. This linkage, determines whether this is an ester or amide. So you have the esters here because of the ester linkage here. And I want to say that, the ester local anesthetics, they're safer as far as systemic side effects, but they are more prone to cause allergic reaction. That's basically the difference. And the metabolism is basically, is done through the plasma esterases that's available in your circulation. If you look at the names, they have only one eye. In this way, you can differentiate between an amide and ester. This one has only one eye. The amide local anesthetics, they have two eyes, like lidocaine, prilocaine, etidocaine. I use only lidocaine. That's the cheapest and available local anesthetic, in the whole world here. Just diluted to half percent. Now, can you use mepivacaine? Yes, you can. It's a short-acting local anesthetic, but not bupivacaine. Okay. And again, this is the difference between an amino ester and amino amide. As I said, this one has only one eye. This one has two eyes in their names here. This one is faster metabolism by plasma esterases, and they're more prone to allergic reactions. While the amides, they're more prone to systemic toxicity. The mechanism of action of local anesthetics are through sodium channel blockade or membrane expansion. Uh, these are the basic theories that every anesthesiologist knows. But there are other theories that you should know as a pain practitioner, like cell membrane restoration, okay, uh, exoplasmic transport blockade, autonomic nervous system resetting. We know that local anesthetics stabilizes neurons in the limbic hypothalamus axis and often leads to long-lasting decrease of arousal and autonomic nervous system. Also, local anesthetics have an anti-inflammatory effect, and there is research from University of Virginia where they found that lidocaine attenuates the cytokine-induced cell injury in endothelial and vascular smooth muscle cells. This is a laboratory work that actually was published in Anesthesia and Analgesia in 2003. So, in this article, they mentioned that lidocaine inhibits the release of superoxide anions by human neutrophils, and also it decreases the release of interleukin 1 beta from human mononuclear cells. Another phenomena that you should be aware about is what we call Schwarzman-Senerelli phenomenon. Okay, and basically, what this phenomenon means in a nutshell here, the tissue memory. Okay, every one of us has a tissue memory. So, if you get injured, your tissues will memorize this type of injury. Next time, if you have the same injury, it will be highly exaggerated. So injecting local anesthetics will actually block this phenomenon, and thus, it blocks the pain in this area. So basically, neurotherapists recognize that tissue memories are neurological programs that can be triggered by activation of interference fields. This is some form of the allergic reactions that are produced by ester local anesthetics. And it's usually, as I said, related to the preservative, which is methylparaben, or the PABA, which is the metabolite of amino esters after being attacked by the plasma esterase. And it could manifest in rash, hives, laryngeal edema, bronchospasm, or hypotension. Now, if I have a patient that had lidocaine and had allergic reaction, this is really extremely rare, guys. So I always, suspect that there is another issue. Like, for example, a dentist injecting lidocaine that has epinephrine in it, and you have systemic absorption of epinephrine. This is not a true allergy. This is a systemic toxicity from the epinephrine, for example. But amides actually, like lidocaine and bupivacaine and others, actually can cause systemic toxicity depending on the amount of the medications you're injecting and the site of the injection. You might have actually starting with tongue numbness, then you can start to have lightheadedness. You can get visual and auditory disturbances, twitching, loss of consciousness, and then it can end with seizure or coma. I remember one time I did an axillary plexus block in a patient, and basically he started to have this, tinnitus in his ears and tongue numbness, and so I gave him some sedation. I gave him midazolam, and this calmed things down until he finished up the surgery. But you gotta be aware about these complications because in these situations, you need to give benzodiazepine. All right, so the patient doesn't seize from it. I put some references, for you guys here. Please look them up. I do believe there's this site here, Lyftoght. Uh, I like this one the most by Dr. Reeves. Okay, Dr. Reeves talked a lot about neurotherapy. Talks a lot about the perineural injection therapies by Lyftoght. And then you have another website, AAOMED, which is basically the American Academy of Osteopathic Medicine. And these guys, they do have, a conference every year. Um, and you need to look it up. It's usually in April. Um, Really, if you're interested in learning these techniques, you need to attend, a couple of these conferences here. I did attend at least two or three. I recall, and they're extremely useful. Okay, thank you so much for your, attendance, and please let me know in the comments if you have any questions. Thank you so much.